Good afternoon. I'm going to make a presentation about common scrotal conditions which one sees in the NHS primary and the secondary care. This presentation is a further review of the common conditions. And in 1993, I had made publications of major reviews on seminomas and teratomas. And these are still visible in my website. However, no significant change has taken place in the condition, symptomatology, investigations, and perhaps the treatment has advanced slightly, but not much. However, these conditions are common in the primary care particularly, and with that bias in mind, I'd like to make this presentation in a short space of time. This condition is best understood with the help of diagrammatic figures and presentations based on descriptive anatomy and embryology. And I'm handicapped because of the copyright restrictions. So I'd show you one simple slide containing the anatomy of the testicles, but I would urge you to supplement this presentation with a recognized printout or a knowledge source relating to embryology, anatomy of the scrotal organs. And with this reservation, I'd now like to start off with my presentation. We are dealing with NICE guidelines and British Association of Urological Surgeons guidelines relating to the current year. So to begin with, let's familiarize ourselves with the anatomy of the testicles, followed by a brief discussion about its embryology, which will make it more logical to explain the disease progression, particularly infections, as well as anatomical embryological conditions. So this is the testicle covered by tunica albuginea, the white tough membrane, and it has numerous compartments separated by various kinds of septas, and in which convoluted secretory tubules are kept called seminiferous tubules. And these produce sperms and its evolutionary form, and these are then connected up centrally towards the hilum into rete testicle. So they go into smaller channels for storage. And they are primarily stored as convoluted tubules would hold the various evolutionary stages of spermatocyte into the head of the epididymis, the body of the epididymis, and finally, to some extent, they are reserved and held in storage in the tail of the epididymis, which then becomes the vas deferens. And the vas deferens travels upwards along with the other components of the spermatic cord via the groin, and the continuation of the vas deferens then goes up to its side of the ureter, loops around the ureter, and then comes down again. And it joins the seminal vesicles, which are glands on either sides of the testicles. And so the vas deferens, swollen part of the vas deferens, joining with the seminal vesicles, form the ejaculatory duct, which opens into the prostatic urethra, and it comes out. I regret it's a monologue, but it's important to understand this through diagrammatic means. So The testicles are therefore male sex organs, and they have an endocrine function in terms of making a steroid, which becomes testosterone, and in terms of exocrine functions, which is spermatogenesis. So it's development, build-up, storage, and release of various sperms in various stages of development. The testosterone production is controlled by the luteinizing hormone of the maternal anterior pituitary, while the sperm production is controlled by the FSH, follicle stimulating hormone of the mother. So going back into this, the testicle is a bean-shaped structure covered over by a white fibrous capsule called tunica albuginea, which contains compartmentalized areas. And these then discharge the hormone or continue to make various kinds of sperms, which goes via channels in the rete testis near the hilum of the testicle for storage into the head of the epididymis, which transmits it further to the body of the epididymis and then the tail of the epididymis, and also via the vas deferens back again into the prostatic urethra, where it joins with the seminal vesicle duct to become the ejaculatory duct. Now, in the part of the testicle where there are organs which produce testicles, these are always under congestive pressure. And where the testicle stores its sperms in the epididymis or head of the epididymis, if the tubules are straightened out and stretched, they measure 20 feet. So all of it is a storehouse for various evolving spermatids. The seminal vesicle, which is a gland which opens up on the sides of the prostate on either side, forms 80% of the volume of the ejaculate, and it contains fructose, providing energy to the sperm, prostaglandin, which reduces the immune response of the vagina, which could treat the sperm as an invader, which changes the fluidity from acidic to alkaline, which allows for transport and survival of the sperm. It has clotting factors as well, which is produced by a gel, and this helps to keep the sperm stay alive for a longer period of time. Now, how does the story start? In the developing fetus, in the retroperitoneal structures, the Y chromosomes lead to differentiations, making a genital ridge. If there is no Y chromosome, then the structure of the genital ridge becomes an ovary. Sertoli cells in that region prevent the Mullerian system into becoming the female sex parts. And so the Sertoli cells then lead to suppression of Mullerian duct at about 8 to 10 weeks of development. However, in some cases, vestigial organs of the Mullerian duct persist, and they are then in the future called appendix testis or prostatic utricle. or appendix of the epididymis. Testicles develop high up in the retroperitoneal region, just above the kidneys, and they are suspended above and below by folds of mesothelium, and the lower one shrinks and condenses, pulling the developing testicle down, and it follows a distinct route. And then eventually, in the last trimester, close to the timing of the birth, the lower suspension, which is gubernaculum, leads the testicle to enter the scrotum, and then the gubernaculum becomes fixed to the soft structures of the scrotum. And as the testicle descends from the retroperitoneal suprarenal position, it drags with it its blood supply, which is an arterial supply, which is testicular artery from the abdominal aorta. And the veins which go up result in a conglomerate called pampiniform plexus. And on the right side, it opens up into the inferior vena cava. And on the left side, it opens up into the left renal vein. If for some reason the descent of the testicle is prevented, then you have various embryological problems, including exposure of the testicle to a higher temperature, and therefore its functions and its anatomy are both adversely affected. Once again, testicle bean-shaped, 3 to 4 centimeter in this direction, 3 centimeter in that direction. Seminiferous tubules open into the hilum and going up for storage of sperms and release of hormones, which is testosterone, in the head of the epididymis, in the body of the epididymis, tail of the epididymis, and then of course through the vas deferens, and eventually opening into the ejaculatory duct with seminal vesicle. So disease of testicle will affect the epididymis, and disease of the epididymis will affect the ejaculatory duct, and therefore it will affect the lower urological structures such as the prostate, the urinary bladder as well, whether it is infective, inflammatory, or neoplastic. We now go on to conditions that we normally see in clinical practice. Epididymoorchitis. There is usually a combination of 3 symptoms: pain, swelling, and inflammation of epididymis and or testicle. 50% of cases which are clinically diagnosed as epididymitis also have orchitis. And because of the anatomy which blends one organ with the other, it's important to understand the anatomy. So what causes epididymoorchitis? It could be a bacteremic infection leading on to enteric bacteria, or viremia causes viral infections such as in mumps or in other viral conditions. It could be a secondary infection caused by refluxing urine containing organisms from the bladder. It could also mean that epididymoorchitis could be caused by sexually transmitted infection, such as chlamydia, gonorrhea, HIV, or chronic granulomatous conditions such as tuberculosis. Rare causes of epididymoorchitis include Behçet disease, which is oromucosal and genital ulcerations, or Henoch-Schönlein purpura, which causes fragility of the vascular tree and in addition, problems relating to spleen and bruising. Brucellosis, tuberculosis, or as a chemical reaction from use of amiodarone. So the clinical features when considered for epididymoarthritis, you need to exclude torsion, which would mean there is a history of either trauma or past history of torsion and detorsion. There could be acute unilateral scrotal pain and or swelling. Particularly with epididymoarthritis, there may be fever, dysuria, urethral discharge, or parotid swelling. Typically, there would be a palpable tender swelling of epididymis and or testicle, and there may be erythema of scrotal skin. There may be scrotal pain and tenderness, which might be relieved by elevation of testicle in a supine position, which constitutes the Prean sign. Epididymoarthritis may present in association with a reactionary hydrocele. So what would be the physical signs of epididymoarthritis? You would need to examine the scrotum on a patient who is standing up and lying supine, and you would need to assess the right side and the left side and both groins, as well as penis and urethra for telltale signs of infection and inflammation. You should exclude an indirect inguinal hernia, which could cause a swelling in this region because of persistence of tunica vaginalis. You need to exclude sexually transmitted infection by taking an adequate and reliable sexual history. One would need to then assess the testicle in terms of the polarity. Is it lying in its right anatomy, size, symmetry, tenderness, swelling, consistency of the testicle, which would be hard and non-tender in malignant conditions, and it will be soft and tender with epididymoarthritis, and whether there is transillumination present, which shows the presence of hydrocele. One would need to examine for abdominal masses or lymphadenopathy, including the supraclavicular lymph nodes. There may be fever or skin changes of the scrotum. Dipstick urine test, if positive for leukocyte and nitrites, might suggest an enteric causative organism such as E. coli. A dipstick test, which is only positive for leukocyte, may suggest STI. So the differential diagnosis of epididymoarthritis includes, number one, torsion of the testicle, and we'll talk about it in detail as we would about testicular cancer. There are skin conditions such as the squamous cell carcinoma of the scrotum, indirect inguinal hernia, isolated epididymitis or isolated orchitis, hematocele if there has been a recent injury, epididymal cyst or spermatocele, hydrocele or varicocele, which is exaggeration and incompetent valves of the pampiniform plexus of veins surrounding the spermatic cord, and then coming over to the upper part of the testicle. So how would we investigate epididymoarthritis? Urine dipstick, culture and sensitivity tests to exclude enteric organisms and also to confirm STI under the sexual health clinic. Urgent ultrasound scan should be done if there is uncertainty, if hydrocele is present in a younger age group, or if there is presence of swelling after trauma to exclude hematocele. Blood tests need to be done for markers of testicular cancer, and we will discuss this under the testicular cancer section. So the complications of epididymoarthritis would mean in an untreated state, it can lead to sepsis, which is an emergency, local abscess formation and ischemia and infarction of the testicle. There could be reactive hydrocele of an inflammatory or infective nature. Untreated long-term conditions produce testicular atrophy and therefore subfertility. There may be development of chronic scrotal pain, which is a neuropathic pain. So how would we provide management? If there is suspicion of torsion or irreducible hernia or sepsis, must be an immediate admission. If there is suspicion of cancer, then a two-week wait referral to urology. If you cannot rule out sexually transmitted infection, then at the outset, without treatment, we would need to urge the patient to self-refer to sexual health clinic. And this would be for suspected chlamydia, gonorrhea, syphilis, HIV, AIDS, and so on. In case it is not possible to make a referral to the sexual health clinic, or if the condition does not necessitate it, then we would need to treat the patient with appropriate antibiotics, followed by a review assessment a week later. The common treatment requires use of ofloxacin, 200 milligrams twice a day for 14 days, or levofloxacin, 500 milligrams daily for 10 days. So the quinolone antibiotic most commonly used in the primary care of the NHS is doxycycline. However, they all act in a similar fashion with slight change in their interaction. Doxycycline is contraindicated in allergy or porphyria. It can produce muscle weakness, induce SLE, can cause hepatorenal damage, and it also excites sun exposure related skin problems as tetracycline. It interacts with antacids and enzyme inducers such as anti-epileptic drugs, insulin, lithium, methotrexate, statin, and warfarin. The dose of doxycycline would be 200 milligrams stat, 100 milligrams daily for 1 to 2 weeks. If the patient is treated in the STI clinic, they usually use ceftriaxone, 1 gram intramuscular, and oral ofloxacin 200 milligram BD for 14 days. Ofloxacin is similar to doxycycline in being a quinolone, but it has significant side effects in relation to myopathy. It can produce tachycardia, prolongation of QT interval, and the dose of ofloxacin is 200 to 800 milligrams per day. The usual dose is 200 milligrams BD for 14 days. So let's now talk about hydrocele. A simple hydrocele is an abnormal collection of serous fluid between the parietal and the visceral layers of tunica vaginalis membrane that surrounds the testicles or along the spermatic cord. So a remnant of this tunica vaginalis can result in pooling of fluid in the entrapped scrotal compartment. And this can happen due to trauma, infection, torsion, or cancer. These are the acquired varieties. Congenital one will be a serous collection of hydrocele in the trapped cavity, because the processus vaginalis would have actually closed down in majority of people. This processus vaginalis persists in 80 to 94% of the newborns, but subsequently closes, but may be present or found in 20% of adults. So congenital hydrocele, how does one manage it? One usually reassures the mother that it will usually close and resolve in 12 months. And this is based on British Association of Pediatric Surgeons, and internet leaflets are available, which we would need to give to the parent. If the hydrocele persists beyond 12 months, or if the hydrocele is associated with hernia, or it is limited to the spermatic cord, then one should refer to the pediatric surgeons. If abdominal mass is present as well, in other words, if this is an abdominal scrotal hydrocele, then an early referral to the pediatric surgeon is warranted. Acquired hydrocele may be sudden or gradual onset. It's typically painless, fluctuant ovoid swelling enveloping the testicles and or located above the testicle along the spermatic cord. Communicating hydroceles, which means that the patency is retained of the processus vaginalis, will lead to fluctuation in size relating to activity or raised intra-abdominal pressure, such as in coughing and sneezing, and it is transilluminatable. Quite often, acquired hydrocele is also associated with varicocele. It is also associated with testicular torsion, testicular cancer, or inguinal hernia. Acquired hydrocele. The differential diagnosis would be to establish if an urgent cause exists requiring admission, such as torsion, such as irreducibility of hernia or sepsis. If the testicle is not palpable easily because of the swelling or tenderness, and if the age group is young, between 18 to 40, then obviously urgent ultrasound scan should be done and patient information leaflet given to the patient about hydrocele. Small-sized hydrocele resolve on their own and do not require any treatment. Urological or pediatric urological referral is needed for large and painful hydrocele, for hydrocelectomy. Older patients can be treated with aspiration under local anesthetic and sclerotherapy. Torsion of the testicle. Torsion is suspected in any patient with acute scrotal pain or swelling before other causes are considered. So, any scrotal pain, unilateral, bilateral, radiating to surrounding structures, occurring very quickly, severely, with some exacerbating factors such as recent activity, injury, or positional change. So these are red flag features which require one to consider the presence of acute torsion necessitating urgent hospital admission. If in addition to pains, there is a scrotal swelling or mass, if there is a previous history of intermittent torsion and detorsion, if there are symptoms of viscous related pain such as nausea, vomiting, or abdominal pain, remembering that sometimes torsion will start after an injury such as a kick. So the physical signs of torsion, it's the polarity, which is the testicular lie. If the testicle is high riding or transverse rather than longitudinal, if there is testicular tenderness, it is present both in torsion as well as epididymoorchitis, but not in cancer. The cremasteric reflex may be absent in torsion, which means that gentle pinching or stroking of the medial thigh causes elevation of the ipsilateral testicle. Pre-ensign, relief of pain with elevation of the testis may suggest epididymitis, but does not rule out testicular torsion. If you suspect torsion, do not arrange for an ultrasound scan, but have the patient admitted and treated because minutes count in terms of salvaging the testicles. So the management of torsion means for sudden onset scrotal pain, and if testicular torsion is suspected clinically, arrange emergency hospital admission to urology or pediatric surgery, depending on clinical judgment. If a person has no current scrotal swelling or pain, but has a history of previous episodes of severe self-limiting scrotal pains or swelling, arrange a urological referral, and the urgency will depend on the frequency and duration of the episodes. This obviously means there is suspected torsion and detorsion. When a referral is made to urology, arranging an ultrasound scan will show presence of a testicular mass, which means possible granuloma or more likely cancer. Whether it is intra or extra testicular, what the volume is, and the location is, and the character is, and what the state of the contralateral testicle is. So these will highlight the current position to the urologist. Testicular cancer. It's the most common male cancer in a young age group, 15 to 45. 1.5 cases per 100,000. There are generally 2,000 new cases recorded in the UK of testicular cancer per year. Highest incidence in developed countries such as Norway, lowest in India, but it's questionable if all cases are diagnosed in developing countries. Testicular cancers are basically germ cell tumors. And nowadays, they are classed as seminomas or non-seminomas. Seminomas arise from seminiferous tubules inside the testicle, And the non-seminous tumors may be embryonal residual cancers, yolk cell tumors, trophoblastic tumors, teratoma, as they used to be called in the past, and then, of course, mixed germ cells tumors, which means that there are some features of seminoma and some features of non-seminomas. So, what are the types of cancers then? There could be germ cell tumors, as I've just described. There could be spermatocytic tumors, yolk cell tumor, and there would be sex cord or stromal cell tumors such as Ladix, Sertoli, granulosa cell tumors, thecomas, and then tumors in other parts of the body such as mediastinum, and there are non-specific tumors as well, but these are very rare. What could be the possible causes of cancer? The commonest association is seen in undescended testicle. Also, men who are infertile and have abnormal sperm counts have a higher incidence of testicular cancer of a germ cell nature. Patients with Klinefelter syndrome have a higher incidence of germ cell tumor. If there is a family history present, then the incidence rises. Taller people are more at risk. If there is presence of HIV or AIDS, it increases the incidence of testicular cancer. It should be emphasized by way of education that vasectomy has no relationship as far as testicular cancer is concerned. Genetically, all testicular tumors show some abnormality of chromosome 12. So the symptoms of testicular cancer, 95% present with a lump which is painless. The symptoms include scrotal heaviness, dull abdominal pains due to dragging of the spermatic cord, hydrocele, which is of a sudden onset, non-resolving. There is a scrotal pain. There could be gynecomastia, and there could be low back pain due to metastatic spread into the retroperitoneal space. Signs of testicular cancer. Lump in nearly all cases, which is non-tender with absent testicular sensation, and it is more firm than normal. Whereas the normal testicle is rather delicate and the inflamed testis is very tender, the malignant testicle tends to lack the normal level of sensation. Remembering that the lymphatics from the scrotum drain to the inguinal nodes, but lymphatics from the testis go deeper to the retroperitoneal nodal system. Therefore, inguinal lymph nodes are unlikely to be enlarged. Differential diagnosis of testicular cancer. Epididymoorchitis, torsion, lymphoma, hydrocele, hematocele, epididymal cyst, hernia. Infections such as tuberculosis, syphilis, and mumps. So the blood tests. Seminomas have poor markers. The only marker they are likely to have usually is LDH, lactate dehydrogenase. Non-seminomas are usually secretive, and therefore they are more aggressive, but with high survival rate. And the markers could include alpha-fetoprotein, human chorionic gonadotrophin, particularly of beta subunits, and lactate dehydrogenase. Alpha-fetoprotein is usually produced by yolk cell and yolk sac elements, but not produced by seminomas. Beta HCG is produced by trophoblastic elements, so it is usually secreted in non-seminomas. Beta HCG levels could be raised both in teratoma and seminomas. An ultrasound scan is fairly reliable in making the diagnosis. So in terms of diagnosis, blood markers, ultrasound findings, physical assessment can lead to a reliable diagnosis of testicular cancer, for which no needle biopsy or excision biopsy in a local wedge area is recommended because of spread of contained cancer into a regional spread. So the best way forward would be to arrange for an orchidectomy and histological interpretation. Staging of testicular cancer. Stage 1, when it is confined to the testicle and it has only involved the local vascular tree, such as pampiniform plexus. Stage 2, when it has spread to the retroperitoneal nodes, which can be in the upper abdomen. When it spreads to the retroperitoneal nodes plus an organ such as lungs or kidneys or liver in stage 3. Stage 4 of non-seminomas will go from nodes to major organs to even brain. So how does one treat seminomas? Stage 1, watchful waiting after orchidectomy with reviews regularly, scans and markers. 80 to 85% patients are okay at the end of 5 years. Stage 1, when there is vascular invasion, then orchidectomy followed by preventive cisplatin. Stage 2, if nodes are less than 1 centimeter, then 3 rounds of BEP or 4 rounds of EP. If the node is more than 1 centimeter in size, then radiotherapy first, followed by BEP or EP. Stage 3, 3 rounds of BEP or 4 rounds of EP. Seminoma has no stage 4, and it has a 95% survival rate. So BEP is bleomycin, etoposide, and cisplatin. EP is etoposide and cisplatin. These were also described in 1993 on a major review that I undertook of both seminoma as well as teratoma. The treatment of non-seminomas, which means possibly teratoma. So these constitute 40% and they secrete alpha-fetoprotein and respond well to chemotherapy. Teratoma, when there is mixed tumor and if it's resistant to chemo and radio, which it is usually, then the best treatment is orchidectomy. For stage 1 non-seminomas, alpha-fetoprotein, beta-human chorionic gonadotropin, and lactic dehydrogenase markers, ultrasound scan, orchidectomy, and surveillance. Stage 2, 3 rounds of BEP after renal function tests. Stage 3 and 4, 3 to 4 rounds of BEP or EP. 50% of non-seminomas have raised markers. The investigations of use are ultrasound scan, CT scan of the abdomen or of the lung, following orchidectomy. So if the treatment is offered, the choices are surgery, which is always the case, orchidectomy, inguinal orchidectomy, chemotherapy, which I have described, radiotherapy in case it's aggressive, and or retroperitoneal lymph node dissection followed by radiotherapy. Follow-up is for several years and relates to blood markers, chest X-ray for lung metastasis, or scans for lung and liver. However, patients who have been successfully treated for cancer of the testicle have increased cardiovascular risks. The prognosis is good when one looks at carcinoma in different organs. It has probably one of the best prognoses. And because of that, it is said to be curable in 95% cases. So we talked about anatomy, embryology of testicle. We talked about epididymoorchitis, hydrocele, possibly hematocele in the same way, torsion of the testis, and cancer of the testicle. I hope you will supplement your knowledge with relevant anatomical and embryological descriptions, as awareness of anatomy is essential in terms of management of testicular or scrotal conditions. I have hoped to have shown you numerous diagrams and photographs and histological slides, but I am prevented due to copyright rules and will rely on you to supplement your knowledge by direct access from the internet. Thank you very much.